Vanakkam. In adult brachial plexus injuries, the findings that you see in the beginning will be the same after many years too, except maybe there may be a little wasting of the muscles or there may be stiffness of the joints. But in birth brachial plexus palsy, it is totally different because of one small thing: the child is growing. It is not only the child that is growing, the nerves are also growing, and they are growing in such a way that they innervate different groups of muscles. As a result, many groups of muscles contract at the same time. This is co-contraction. The next difference is that the muscle imbalance is going to show up very greatly. How to assess the problem? How to assess the muscular imbalance? How to assess the co-contractions? All this and more in this video. We have seen the clinical examination of birth brachial plexus palsy in infants, the clinical, anatomical and physiological classifications, and understanding the prognosis of such problems in the previous video. We shall now be seeing the sequelae that occur in birth brachial plexus palsy as the child keeps growing, and the clinical examination in grown-up children in this video. Before learning the clinical examination of birth brachial plexus palsy in growing children, first we need to understand what happens as the child grows in this condition. Firstly, infants who recover partial anti-gravity upper trunk muscle strength, that is the biceps, in the first 2 months of life should have a full and complete recovery over the first 1 to 2 years of life. Infants who do not recover anti-gravity bicep strength by 5 to 6 months of life, the outcome will be poor and microsurgical reconstruction will be needed. Infants with partial recovery of anti-gravity strength during the months 3 to 6 will have permanent progressive changes developing. And what are these changes that happen to these upper limbs affected by birth brachial plexus palsy? And more importantly, why do these changes occur? There are two main causes of changes following primary birth brachial plexus palsy with or without nerve surgery. The first is aberrant regeneration due to misdirection of regenerated axons leading to the phenomenon called co-contractions. The second cause is muscular imbalance and growth. Let us first consider the co-contractions. It refers to the phenomenon where two or more groups of muscles contract at the same time. They may be the agonist and the antagonist also. This peculiar phenomenon can be explained with two different mechanisms. Developmental apraxia can cause a central motor program deficiency due to poor sensory motor stimulation of the brain during a critical period of neuronal maturation. So the central nervous system has a role to play in these co-contractions developing. The second is the consequences of axonal repair with axonal splitting and aberrant nerve growth, which can occur even without the axonal repair. Let us try to understand how this co-contraction occurs due to aberrant nerve growth. Nerves always contain different fibers going to different groups of muscles. Let us consider this example of the blue fibers going to muscle group A and green nerve fibers going to muscle B. When there is an injury to this nerve, like in this diagram, a scar tissue forms between the two ends through which the proximal nerve fibers try to grow. In infants and children, this growth potential is high. The blue fibers may grow and ultimately reach muscle A, which they are intended to supply. But they may also grow and reach muscle B, which is a totally different muscle. So now when the patient wants to contract muscle A, muscle B also contracts at the same time. This is known as a co-contraction. Usually we see co-contractions in 4 different combinations. The first is the co-contraction between elbow flexors, mainly biceps and brachialis, and the shoulder abductors, mainly the deltoid. So when the patient is asked to abduct the shoulder, the elbow flexors automatically contract together with them. and vice versa. When asked to perform a hand-to-mouth movement, the shoulder will involuntarily be elevated. This is the trumpet sign. The next common type of co-contractions that occur among the shoulder abductors, elbow flexors and forearm flexors. When the patient is asked to perform shoulder elevation, the elbow and fingers flex involuntarily. The wrist also is seen to flex along with this movement when trying to catch an object. The next type of co-contraction between the elbow flexors, that is the biceps and brachialis, and the elbow extensors, that is the triceps, which is seen by extension of the elbow trying to occur when the child is trying to flex the elbow. This can be noticed by palpating the contracting triceps along with attempted elbow flexion. As a result, there is no useful movement of flexion. This particular category of co-contractions can be categorized into two types. In the mild type, the patient will be unable to perform elbow flexion normally, such as pulling up the trousers or hand to flank or hand to spine movements. In the severe type, the child will be unable to perform a hand to mouth movement. Flexion contracture of the elbow eventually develops. The final category of co-contraction occurs between the shoulder abductors, the supraspinatus, infraspinatus and deltoid, and the shoulder adductors, mainly the teres major and pectoralis major. In the tussle between these two groups of antagonistic muscles, the result is a limitation of shoulder abduction. And not only that, the shoulder adductors or internal rotators, which are much more powerful, will cause a contracture of the shoulder in the growing child. We shall now consider the muscle imbalance that occurs with growth. This muscle imbalance involves mainly the shoulder and elbow. This is because flaccid paralysis of the shoulder and elbow is rare, but flaccid paralysis is commonly seen in the forearm and hand due to root avulsion of C7 to T1 without aberrant regeneration. So aberrant regeneration is more common in the shoulder and elbow, which leads to a muscle imbalance. Let us first consider what happens to the shoulder. Strong active external rotation is an infrequent outcome, either spontaneous reinnervation or surgical neural reconstruction. Even if the external rotators, that is the infraspinatus and teres minor, do recover or become reinnervated, they are severely disadvantaged in their contest against the very powerful internal rotators, that is the pectoralis major, teres major, latissimus dorsi and subscapularis. These strong internal rotators now become shortened, the anterior capsule gets tightened and the coracohumeral ligaments foreshortened unless passive range of motion exercises are compulsively performed, or sometimes these changes happen in spite of the therapy. So there is a significant imbalance of muscle forces acting across the growing glenohumeral joint. So as a result, these vectors push the humeral head posterior until it subluxates. In this posterior position, the humeral head now begins to deform and the glenoid recontours. With time, the humeral head becomes less rounded, more oval, and may develop areas with differing radii of curvature. Now, as the joint moves back and forth along these two radii, it is characterized by a click or clunking of the shoulder. If untreated, the shoulder will remain posteriorly dislocated. Now, these changes that occur in the glenohumeral joint is progressive with age and appears quite early in infancy. Waters and colleagues have described various grades of the deformity that can develop. Considering this as a representation of the normal configuration between the glenoid and the humeral head, which is considered grade 1 in the Waters classification, increased glenoid retroversion is grade 2, posterior glenohumeral subluxation with posterior glenoid dysplasia is grade 3, development of a false glenoid is grade 4, flattening of the humeral head and the glenoid is grade 5, and true infantile glenohumeral deformity is graded as grade 6. When there is proximal humeral growth arrest, it is considered grade 7. We should remember that when this deformity is established, it is impossible to recover normal passive external rotation of the shoulder by measures like splinting, functional taping or bracing or exercise. This will typically need surgical correction. In severe involvement of the C5 nerve root, all of the muscles that stabilize the scapula are involved. It leads to what is known as a shear deformity, scapular hypoplasia, elevation and anterior rotation. This deformity can be well documented with a 3D CT. We shall see more about this deformity in the upcoming videos. We have seen what happens to the shoulder in a growing child with birth brachial plexus palsy. But what are the changes that occur at the elbow? Four major problems can occur: failure of biceps recovery, elbow flexion contracture, loss of supination, and supination contracture. Usually, the biceps recovers with time, but when the biceps does not recover at all, it becomes a problem and elbow deformities develop. But even if the biceps is acting, there is a typical mild contracture of 20 to 30 degrees in the majority of children with birth brachial plexus palsy. This may be related to fibrosis of the muscle as a consequence of the trauma of delivery. Loss of supination of the involved forearm is found in many children. It could be due to subluxation or dislocation of the radial head, but since pronation is the more important function, this problem of loss of supination is not usually given much importance. A few children with global palsy may develop a persistently supinated forearm. And what happens to the wrist? Usually, there will be inadequate wrist extension. In children with global palsies who fail to regain adequate wrist extensor function, we need to check muscles like the flexor carpi ulnaris or the abductor pollicis longus to be available for tendon transfers. And in the hand, poor finger flexion, poor thumb opposition, and inadequate digital extension are the problems seen with these children. We also need to realize that overall, we can expect an average of 10% difference in the upper limb length with incomplete recovery of a birth palsy. And the more severe the neurologic involvement, the more substantial will be the limb length discrepancy. What was not possible in the clinical examination of the infant was voluntary testing of muscles and movements, but this will be possible in growing children. Before we begin the voluntary testing of movements and muscles in children, there are certain tests and signs that can be elicited. The trumpet sign, the cookie test, the putty sign, and the pedi-wrap test. The trumpet sign is one of the commonest signs that is seen. For this sign to occur, there could be a co-contracture of the deltoid and biceps when the child tries to place his or her hand to the mouth. The second reason is that, lacking good external rotation, the infant or child learns that if he or she is to reach the mouth with the hand, the arm must be brought away from the body before the elbow is flexed. I shall now demonstrate what happens. When I want to bring my hand to my mouth, there are three movements that must occur. 1. The shoulder must externally rotate, the elbow must flex, and the forearm must supinate. All or some of these movements may not be possible in children with birth brachial plexus palsy. So what they learn to do to bring the hand to the mouth is they flex or abduct the shoulder completely so that the flail elbow or the weak elbow flexion will now bring the hand to the mouth. This position resembles the posture of blowing a trumpet. Hence, it is known as the trumpet sign. It indicates that the shoulder external rotators, the elbow flexors, and the supinators are weak. The amount of shoulder abduction that occurs with the trumpet sign can also be quantified. When the angle is more than 80 degrees, it is known as severe cross innervation and is an indication for surgical correction. When the arm to body angle is less than 40 degrees, it is referred to as mild cross innervation. The cookie test is done to assess biceps function. A cookie is placed in the child's hand on the affected side. The child will automatically want to take the cookie to the mouth. The examiner holds the child's shoulder adducted at the side to prevent compensation for biceps weakness by abducting the shoulder. I shall now demonstrate what happens in the cookie test. When my shoulder is held adducted by an examiner and I want to take my hand to my mouth, but my biceps is not strong enough, I will be able to flex my elbow only for a certain distance. And to compensate for this, because I am not allowed to abduct my shoulder, I will flex my neck and try to bring my mouth to the hand. If this angle of bending the neck is more than 45 degrees, the child has failed the cookie test. It indicates that the biceps muscle has not fully recovered. When on passive external rotation of the shoulder, there is compensatory scapulothoracic motion resulting in elevation of the superomedial border of the scapula. It is known as the patti sign. Internal rotation contracture of the glenohumeral joint is evidenced by the clinical picture of this sign and posterior subluxation of the glenohumeral joint made out radiologically. If there is a co-contraction between the shoulder abductors and elbow flexors, we can apply a pedirap, which is an elbow extension splint, to the involved elbow. This will prevent any flexion at the elbow joint. When this is done, shoulder abduction will be better because the elbow flexors have been neutralized in the shoulder abductor biceps co-contraction problem. The posture of the growing child who has had a birth brachial plexus palsy will also be typical. The arm is kept elevated at the shoulder and held either across the chest or abducted at the shoulder and internally rotated. The presence of an extra skin fold crease at the proximal humerus also indicates internal rotation contracture at the shoulder. We must examine the passive range of movements of all the joints in the involved upper limb and compare it with that of the normal limb. We need to note any contractures: internal rotation contracture of the shoulder, flexion contracture of the elbow, supination contracture of the forearm, etc., and it must be documented. We then need to check the active range of movements in all the joints. To do this, we need to check the 16 movements as in the active movement scale described by Clark and Curtis. This has already been dealt with in the previous video. After checking all the active movements in the upper limb, we need to grade the functions of the three important joints: the shoulder, the elbow, and the hand. To grade function at the shoulder, two important scoring systems can be used: the Mallet score and the Gilbert score. The Mallet score, described by J. Mallet in 1972, provides a quantifiable assessment for global shoulder function. It is usually done after 3 years of age because it requires cooperation of the child. Of course, limitations in passive range of motion can alter the interpretation of the results. There are 5 different movements that are tested in this Mallet scoring system. In all these movements, grade 1 refers to no function and grade 5 refers to normal function. This test is very important to determine the results either of spontaneous recovery or surgical intervention. Let us see the 5 functions that are tested according to the original Mallet score and the 6th function that is tested in the modified Mallet score. The first function tested is active abduction of the shoulder. If the active abduction is less than 30 degrees, it is grade 2, 30 to 90 degrees, it's grade 3, and more than 90 degrees, it's grade 4. Next, the external rotation is tested at the shoulder. If there is no external rotation at the shoulder, it is grade 2. If there is less than 20 degrees of external rotation, it is grade 3. And more than 20 degrees of external rotation is possible, it is grade 4. This method of testing the external rotation tests the gravity eliminated external rotation only. These grades are also supposed to represent the condition of the glenohumeral joint. Grade 2 indicates glenohumeral subluxation. Grade 3 may represent glenohumeral retroversion, and grade 4 may indicate a normal glenohumeral joint. The next test is to ask the child to take the involved hand behind the head. This tests external rotation against gravity. If the child is not able to do it at all, it is grade 2. If it is difficult but the child does it, it is grade 3. And if the child does it easily, it is grade 4. Next, the child is asked to take the hand to the back. This maneuver tests both internal rotation at the shoulder and flexion at the elbow. If the child is not able to do it, it is grade 2. If the child is able to take the hand to the back but only to the lumbar region, it is grade 3, and the child is able to take the hand up to the dorsal spine, it is considered grade 4. Then the child is asked to take the hand to the mouth. If the typical trumpet sign is present, it is grade 2. If there is mild accompanying abduction of the shoulder, it is grade 3, and the child is able to take the hand to the mouth but the abduction of the shoulder is less than 40 degrees, it is grade 4. The modified Mallet score tests one more function. The child is asked to take the hand to the midline and touch the abdominal wall anteriorly. If the child cannot do it, it is grade 2. If the child can touch the abdominal wall but with wrist flexion, it is grade 3. And if the child is able to apply the palm flat on the belly without any wrist flexion, it is considered grade 4. The Gilbert scoring system can also be used to grade the function in the shoulder. Stage 0 represents a flaccid shoulder, while abduction of the shoulder beyond 120 degrees with complete active external rotation is classified as stage 5. Just like the scoring systems available for evaluation of the shoulder function, there is a system for evaluation of elbow function which has been described by Gilbert and Raimondi. This system first evaluates the active flexion in the assessed elbow. If there is nil flexion or some contraction, it gets a score of 1. If there is incomplete flexion, a score of 2, and complete flexion gets a score of 3. Next, the active extension range is checked at the elbow. If there is no extension, it is score 0. If there is weak extension, score 1, and good extension, it is score 2. Along with active flexion and extension, the extension deficit is also measured. If there is an extension deficit from 0 degrees to 30 degrees, it is given a score of 0. If there is an extension deficit from 30 degrees to 50 degrees, it is given a score of -1, and if there is an extension deficit of more than 50 degrees, it is given a score of -2. All these scores are added to get a sum total. The hand function can also be assessed in the birth brachial plexus palsy patient by the Raimondi scoring system. This system takes into consideration the supination at the forearm, the flexion of the fingers, extension of the fingers, and movements of the thumb, especially opposition. In this way, the documentation must be complete in the form of a chart before planning the reconstructive strategy for the sequelae of deformities of shoulder, elbow, and hand. So, in a case of B2P2 or birth brachial plexus palsy, we have been able to make a diagnosis based on a clinical examination, whether it is an infant or a grown-up child. The next step is to do the appropriate investigations to help us in confirming the diagnosis and also giving us more insight into the problem. But will an MRI and CT scan help us in birth brachial plexus palsy as they do in adult brachial plexus palsy? That will be discussed in the next video in this series on birth brachial plexus palsy. I hope you enjoyed the video. I enjoyed making it. Please do click on the shown links to see more on the introduction to birth brachial plexus palsy and the video about the etiology of birth brachial plexus palsy. And do not forget to subscribe to stay connected with the latest in learning hand surgery, trauma surgery, plastic surgery and ethics. Vanakkam.